Thank you so much. Well, it is a pleasure to be able to share this roundtable with these specialists. I have given talks and I've shared them with neurologists, and opening it to other specialists. It's the way to offer a multidisciplinary approach to be able to treat these patients who sometimes we see like in small parts, but when we put them together in a whole, obviously the knowledge and the treatment will be much better. I would like to share a presentation with you to try to have a more didactic talk. I would like to divide it into 3 parts, and I'm going to try to stick to the time established. I'm going to explain what migraine is. We've all had sometimes headache, but when we talk about migraine, we need to know about it and we need to diagnose it. Then I'll try to introduce the biochemical basis that we know on which histamine is involved. And finally, and taking advantage of the experience, and in order to give scientific weight that we count on at the moment, I would present the study that we did, thanks to which we saw that patients with migraine could benefit from this treatment when the symptoms, in order for the symptoms to improve. Okay, migraine is a neurological disorder. Yes, so far, and in the next few years, we'll see about this and what we decide. The main symptom is headache. We also have dizziness, so it's a complex patient, and sometimes that will be manifested in one way or another. And in our specialty, it's the main reason for consultation. We have patients with Alzheimer, multiple sclerosis, etc. But migraine is the pathology that in which we have patients in our surgery, and in spite of having so many patients, we don't know a lot on what it's about. So it affects a lot of people, 12% of the population, and every time I do a talk, I continue updating this. If you look it up in Google, the figure was much lower. We have for 108 million of them, and if we look it up in Spanish, migraña, then we have more than 4 million, nearly 5 million quotes and sites that talk about migraine. So this is a very, very common problem, and people are very much interested in it. So we all know that migraine has different phases, and this is a pathology that exists in men and women. But with the hormone change, there is an increase that can make it that 25% of women can have a migraine. It's true that with the years, we see that this is one of the pathologies that can improve with age, because when we are in a menopause process, if there is a decrease of hormonal cycles, then the incidence would be the same as in men. But during the fertile time, women have suffer, and we would say like 1/4 of the population in higher and lower degree, not with the same frequency or intensity, of course. And so we have to diagnose it, and so far it's a clinical diagnosis. We need to listen to the patient. We have to see what kind of pain it is, what the characteristics of it are, and we have to try to put it within the criteria of the International Headache Society, which is a universal diagnosis criteria. So a slight headache, a slight dizziness wouldn't be a migraine if it doesn't comply with the very strict criteria. It's very important to have a very good diagnosis, because you could have any other kinds of pains that have nothing to do with DAO deficit. We try to treat it in that way, and then this would be a therapeutical failure. So it's basic and fundamental to have a good clinical diagnosis. It could be with the aura, without it. There could be patients that have it occasionally, or patient that say they have a chronic migraine because its incidence is of more than 14 days a month. And as you can tell, and so many days of pain, of severe pain in a young population, that means a great loss of quality of life. And most of these studies that are being carried out now, they focus on to what extent this pathology damages the quality of life of patients. And currently, it's one of the 5 most important health problems of active population. And if we think about it in terms of economy, it makes us lose 60,000 working days in our country. So that economically, that would be quite dramatic. So we have a pathology, and we're talking about what is it? Why is there that pathology? We don't know it too much, but there are things that we know, that we've had biochemical studies, and we have 4 mediators in the generation of migraine: nitric oxide, serotonin, calcitonin gene-related peptide, which is the most modern treatment that acts at that level, and finally histamine, which is something that we're dealing with today, but that would be related to a metabolic cascade, an inflammatory cascade, in which the different parts would be divided into these 4 main molecules. And we all know that histamine is related to multiple other things. It's a mediator of allergy, gastric secretions. Histamine is good. It's not like cholesterol, but the excess of histamine would be negative. There are 2 ways of degradation. And then our friend DAO would be present in these 2, and it's essential. And here we have the diamine oxidase, which is this proteinic molecule that is created in the bowel and the kidney, where it was extracted mainly now, and in the placenta as well. And women that have had migraine during the pregnancy, during the time of the pregnancy, they haven't suffered from migraine. The beginning, it's a little bit more complex, but then they just have no migraine episodes. Why? Because placenta is a great producer of DAO. It's protecting this woman with migraine. But after they give birth, they would go back to their DAO phase before that pregnancy. We all know that this activity has been studied, and it's marked around 80 degradation units per milliliter. And, well, excuse me. Okay. Then we have genetic intolerance or acquired DAO intolerance. That would be the two ways of having it. We have a diagnosis, we have some clinical basis, and as doctors, we need to base on scientific evidence. Theory can be very plausible, and we can have some signs, but the way in which we have to do our game nowadays is to have a clinical trial to see if that hypothesis of patients with DAO deficiency who have migraine, if when we correct that deficit, that would mean symptomatic improvement. As a neurologist, we carried out this study based on the main migraine symptoms. That opens the door to other pathologies, but we focused on this. A unicentric study following all the advice of research, having an ethic committee, etc. And the objective was, on the one hand, well, we divided into 2 parts. Seeing what was the prevalence of DAO deficiency in patients with migraine. It's a significant one. It affects many migraine patients. Or if it was only a small population that maybe we would have overestimated. And then with these patients, with these migraine symptoms, we would have a clinical trial, double-blinded, with administration of a DAO and a placebo, on the other hand. And we value the different variables, among them the number of crises, the duration of the crisis. So it's not the same as having 1 crisis of 3 days or 2 crises of 1 hour. intensity of pain. We're talking about a pain with a moderate or severe intensity that can potentially have an impact in the life of the patient. And finally, the need and use of painkillers. You know, triptans is a very powerful analgesic, and the overuse of them, of course, can be counterproductive because it can chronify pain. We carried out this double-blinded study compared with to a placebo. And of course, we had our inclusion criteria, having this deficit, covering all the criteria, signing the informed consent, and exclusion criteria, pregnant women, patients that were taking other drugs that could interact with the DAO treatment. And it was very peculiar to see Arab patients because of some religious reasons. They couldn't eat certain meat derivatives, and those patients couldn't have this product, which was actually taken from pig kidney. So the doses were 3 times a day, and we wanted to value how these parameters affected. So hours of pain, number of crises, intensity of the pain, and the use of analgesic drugs, triptans mainly, which would be the typical kind of analgesic drug. When we had results at the beginning of the study, we were very, very surprised, because out of those 137 patients which were diagnosed with migraine, 87% had a DAO deficit. So we're talking about nearly 90% of patients with migraine. There are very few pathologies that we can associate to DAO in such a clear way. We did it with also with the healthy population, because we wanted to know if maybe that deficit was very common. But no, that deficit didn't go over 30%. It's not something that we should ignore, but these could have other symptoms, maybe digestive or skin-related ones. But at the beginning, we saw that migraine sufferers, in nearly 90%, they have actually a DAO deficiency. It's true that in a second try analyzing whether they had a higher or a lower deficit, that didn't mean more crisis or more intense crisis. We don't know why. These are data that we analyzed later on, and we couldn't really explain it. In the study, we had more women than men, as I said before. The age, as we said, it was middle age, among between 40 and 50 years old. A sample which was very comparable to the data. So the data we could take it to normal population, and the DAO levels, it was 80 and over, and in our populations there was an average of 53. So there was a clear DAO deficit. The first value was the number of crises. They got reduced. We didn't reach the statistical difference because it was a very short study, which is 1 month. So we're convinced that if we had continued, this difference that is slightly appears in the graphic would have increased, and we would have reached the statistical difference. But if we did it in 1 month, we had the power of seeing whether, if this change in patient habits, if in 1 month we already had results, like we will see, then we were talking about something very powerful, and we didn't have to wait for so long to get results. So as we said, duration of crisis, it's worse having a long crisis than having several shorter crises. Here we could see that clearly population treated with DAO supplementation improved in their crisis. They were much shorter. The pain scale here was quite stable. We used the EVA assessment. This is very good for acute pain, but if it's a patient that has migraines quite commonly, they usually go to the middle part of it, and maybe there is kind of some difference here. And then finally, the use of analgesic triptans. there was the need of triptans. It's a powerful analgesic drug. The group which received this DAO supplementation could reduce the use of those. So in 1 month, the duration of the crisis could be reduced, and we needed less analgesia for them. So of all of the population, they completed the study except for 2 patients. When we opened the blind group, it was a population with placebo, and in all the patients that we treated, there were no adverse effects. And we think this is because as the enzyme is very similar to the one expressed by the body, it's not a drug, then it was very well accepted and tolerated, and it didn't cause any side effects. And finally, after the study, and to conclude my speech, we could highlight, quite surprisingly, if it was a result which was even greater than the one we thought about at the beginning, a great prevalence of DAO deficiency in patients with the clinical criteria and a diagnosis of migraine. I insist a lot in diagnosis. We're going to treat migraines and other different kinds of headaches with many reasons and cases, but if a patient suffers from migraines, then we have to think that nearly 90% of these patients have this DAO deficiency. If we supplement it, then the duration of the crisis will be reduced, and we will see a tendency for the number of crises to be reduced as well. There is a reduction of the use of a powerful analgesia, and there are not many side effects. And I would like to insist that we got this result in a very brief period of time, 1 month. And we think that we would make this period longer, then the result would be and will be much better. And finally, we are taking the first steps in this pathway. This is a path that is bringing different spheres together. Sometimes we've been doing it alone, and with this tendency to despair and exhaustion. But it's a wonderful path that will take us to many places, and it's going to improve the quality of life of many of our patients, and in my specialty and other ones that my colleagues are working on. And without further delay, thank you so much